heart recording in case of anything. So when you look at this patient, it is 18 years old, which is actually like younger than 40 years old. So younger age is one of the typical even like presentation like for this type 1 DM patient. So you have seen the sugar levels, both the fasting and the postprandial glucose levels are very high. Like this one is above 126 and this one is actually above 200 with polysymptoms, the polyuria and polyphagia. Okay, then have you seen even the significant weight loss the patient is actually having, like 12 pounds of loss, but they're actually saying it is due to anxiety associated with her new area so that she can adjust for new environment. But it can be because of type 1 DM, because of the catabolism of protein and fat. So this ultimately causes significant weight loss. Then apart from that, have you seen the remarkable respiratory tract infection and vaginal candidiasis? Moniliasis is a type of yeast infection, is mostly like candidial becum. So this is, remember, when the sugar level is high, it is a good environment for the growth of microorganisms. So the patient will suffer from recurrent infection, including vaginal candidiasis and respiratory tract infection. Those are clear indicators which are consistent for the finding of this diagnosis. When you look at the family history, it is negative, especially in type 1 DM. As we mentioned when you are discussing, the most likely causes is usually autoimmune condition. So as a result, like the possibility of inheritance or genetic predisposition is very likely. So this is one indicator. Okay, she takes no medication. That is why she's actually having. Then we have seen even the glycated hemoglobin level, which is very high. And okay, there is a trace amount of urine ketone. That one is more of negative finding, very minute. So that is not really clinically significant. So those are the parameters that are consistent with the diagnosis of this patient. Okay, then. So this one we have already said it before. That is very, very important. Then have you seen even the clinical presentation? Don't you think the features are relatively more of acute onset of symptoms? Huh? It actually even like happens suddenly after some point. There's also trace ketone in the body, which is ketone in the urine, negative family history, and relative young age at the onset. Those are consistent findings for type 1 DM. Then the next question is, now AH will be started on insulin therapy on this visit. Now, this patient is having type 1 DM, which the finding is consistent with type 1 DM, then she's about to start insulin therapy. So what are the goals of therapy? And will normoglycemic prevent the development or progression of long-term complication? So what are the goals of therapy for this condition? Annette. Annette, are you available?
Yes, I'm available.
So what do you think about the goals of therapy? Like she's about to start insulin.
First of all, is to improve her quality of life.
Mm-hmm.
Number 2 is to lower the levels of glucose in her system to make them back into normal levels. Also to help her with the symptoms she's experiencing. So the polydipsia and nocturia. So it's something that if medication can be done, that can be able to eliminate that, then that is okay. Yeah.
Okay, good. Then what do you think? Will normoglycemic prevent the development or progression of long-term complications? Maybe another person, because we are 42. Then Makina.
Pardon the question.
So will normoglycemia prevent the development or progression of long-term complication?
I'm not sure.
So what does the question tell us? Okay, then. Myra? Myra?
So can I try? Not
Okay,
sure.
please. Yes.
I think it's true that it would help prevent progression to long-term complications because since there is no insulin is very less, so controlling the sugars will help to compensate that. It will not be a burden on the body.
So as long as we are controlling the sugar level, thank you, Amina. As long as we are controlling the sugar, we can actually even prevent the long-term complications of DM. Then, Dorothy, are you
Yes,
available? So what
yes.
can you give us some examples of long-term complications of DM?
Like diabetic ketoacidosis.
With long-term complication?
Okay, I remember this also blindness.
Retinopathy?
Then end-stage renal failure, end-stage renal disease.
Yes, there is a renal damage, a retinopathy. Sorry, nephropathy. Yeah. Okay, good. Okay, fine. So the goals of therapy in almost DM patients are to prevent acute and chronic complications. The acute complications are like the DKA, the HHAs, and even the hypoglycemia as a result of the treatment. So remember, like the ADA metabolic goal, the glycated hemoglobin is supposed to be like less than 7%. So when you say optimum control, it's supposed to be like less than 7%. Okay, so when the patient is actually having optimum sugar control, it actually even prevents the development and progression of long-term complication, especially the micro and macrovascular complications. Okay, then now the patient is about to take insulin. So what kind of instruction can you give to the patient about the administration of insulin, which is very simple and straightforward question? Heaven?
So like subcutaneously.
Like what instruction? Yeah, yes, you're supposed to administer subcutaneously. So, but can you give like the patient clear instruction about the administration of insulin?
Okay, they should rotate the rotation of the injection sites, so like to minimize lipohypertrophy and buildup of fat, which usually prevents like the proper absorption of insulin. Yeah.
Okay, good. Yeah, that is one. You have to give clear instruction about the importance of rotation of the injection site because lipohypertrophy ultimately affects the absorption of the drug. Okay, good, thank you. Then any other person face or any volunteer?
So can you say they shouldn't shake it? They should just roll it between their palm.
Yes. So why we are not checking?
It could degrade the insulin as it's a protein.
Yes, there is a possibility of degradation, and apart from that, clamping and the sticking of insulin preparations are very common. That promotes a loss of the potency. Okay, good. Then any other, you have to tell them if they are going to check it, most likely they are supposed to like move it like top to down. Okay, any other?
Injecting on the lower part of the stomach has the highest absorption for the insulin, and probably on the thigh.
Yes, like abdominal area is the highest rate of absorption. So you have to give them, you have to properly advise abdominal area is the best place for administration of insulin. Any other? Any other?
They should prevent. They should prevent any air bubbles in the insulin injection.
Yes. Why we need to fear the air bubbles?
It can reduce the amount of insulin to be administered.
Yes, it can actually even interfere the quantity of insulin that we are going to inject. So that is why we are supposed to be very careful air bubbles. If we notice, we are supposed to actually even dispense back the container, then we remeasure it again. That is good. Specifically, the problem of air here is just affecting the quantity, like it affects the quantity. But in terms of intravenous route of administration, it can actually even cause air embolism. Remember, air can actually even cause blockage when it is administered intravenously. Okay, thank you so much. Any other instruction we need to give them?
Can you say that you should change the, what is it called? The area that you're injecting. If you inject it, let's say today.
Yes, rotation, it has been said. Any other?
Can we also talk of the fact that with injection, you're supposed to be careful to ensure you have an aseptic area. So ensure you disinfect the area you're supposed to administer the insulin to, because it can cause a high risk of infections as you administer the medicine.
Exactly. That means you have to swab the area of the injection with alcohol-based like antiseptic agents. So that is important. By the way, they are going to put like alcohol swab with the cotton, then they swab the area before they inject. Okay, good. So those are the major aspects we need to give. Then apart from that, remember, it is the role of the pharmacist who is supposed to give proper demonstration about the injection technique. So they're supposed to pinch the skin swab first, even not only even the area of the injection site, but even like the rubber part of the insulin vial. It is supposed to be swabbed with alcohol so that it is supposed to be like disinfect properly. Okay, then. So what are then swab, alcohol swab is very important, including even the rubber stopper, as I mentioned before. This one is just to prevent the possibility of infection. Then to inject insulin subcutaneously, remember the patient is supposed to like firmly pinch up the area to be injected. Then they're supposed to inject like at 90 degrees. Yes, perpendicularly. Then quick insert of the needle at 90 degrees. But sometimes if the person is actually very thin, 45 angle is usually recommended in case of like very thin, or in case of infants or very thin individual who have little subcutaneous fat, maybe 45 degree angle can be recommended. But most of the time, unless there is an exception like this, a 90 degree is the recommended injection for insulin administration. Okay, then apart from that, The skin pinch should be released and the insulin is injected. Then we have to apply gentle pressure should be applied at the site of injection for 5 to 8 seconds to prevent the leakage of insulin as needed. So that is very, very important. Then the site should not be massaged, by the way. So generally, the site of the injection should not be massaged after the injection because massage will accelerate the absorption and onset of action of insulin. So, like undesired adverse effects such as hypoglycemia can be happened if you massage the area. So, massage is not recommended. We can actually require the patient to hold for the 5 to 8 seconds after injection, just to prevent the backflow of or the leakage of insulin to the surface of the skin. So those are the general recommendation when a patient is having, when the patient is actually injecting subcutaneous insulin. Okay, then now you can actually even take like how many minutes? I think 3 minutes is sufficient to go through and internalize the question. Then I will get back to you after 3 minutes. So I encourage all of you to read the question as much as you can. Okay, fine. So who is willing to give us the summary of the case study? It is very simple. Any volunteer?
Sir, can I try?
Yeah, please.
Okay, LH is a 45-year-old woman. She's overweight. She's Mexican. She has central obesity. Those are her parameters. She was referred to the diabetes clinic by her gynecologist since she had like candidal infections and noted glucosuria and oh yeah, she had candida infection. So, and she had also glucosuria on routine urinalysis. She had an FPG of 150 mg per dl and 167 mg per dl, and her A1C was also checked and it was 8.2%. She doesn't have it. She said she doesn't have any symptoms of polyphagia and polyuria, but she's been getting more thirsty than usual, and she complains of lethargy. She just gets tired all the time. She has other underlying conditions like hypertension, and she has the monilial infections, and she's on those medications. And being told she's given birth to 4 children with the following weights, and was told that her last pregnancy had borderline diabetes. Yeah, she has been smoking 1 pack of cigarettes per day. She drinks at least she drinks wine occasionally, and she has at least she drinks also at least 2 regular sodas and has a large glass of orange juice every morning. Her physical activity is just walking, and she has a familial history of type 2 diabetes, and all her sisters, aunt, and grandmother have weight problems. Her mother is alive, but her father died at age 47 of heart attack. Yeah, the laboratory levels are as follows. For glucose, it's 147. TIGs is 400 mg per dl, and HbA1c is 8.3%. All other values look normal, and she's diagnosed with type 2 diabetes, and yeah, that's it.
Okay, fine. So, like before you leave Anita, so what are the features that are consistent with the diagnosis of this patient for type 2 DM?
The features that are consistent with type 2
DM for this patient, like the history and the physical examination.
Okay, first I'd say the FBG, which is at 126 mg per dl. So the fasting, is it 150? Yeah, she has a fasting blood glucose of 150 milligrams per dl, which is a bit high. And then her HbA1c is above the normal range of up to 6%, so it's at 8.3%. And I think she has a high BMI. You've highlighted it.
Yeah,
so
yes.
she has a high BMI of 27.5, which is a risk of obesity, which is a risk factor for diabetes, type 2 diabetes.
Okay.
Yeah, and also family history may suggest that it's true that she has type 2 diabetes. And also, I don't know, I think the baby she delivered looked a bit overweight. So I think that's because I don't know, the macrosome of the babies is a bit suggestive. And yeah, she has the mild symptoms where they're being told she says she feels a bit thirsty, and she has a bit of lethargy. And then she also has I think the consistent infections of the monilial infections. And yeah, I've also seen, I don't know, that the TIG, is it? The triglyceride.
Yeah, triglyceride level is actually very high, which is very common in type 2 DM. Yeah, because it can cause insulin resistance.
Yeah, that's what I'd say. And I don't know whether she has hypertension. I don't know. I'm not sure.
Okay. She has hypertension, and hypertension is one possible risk factor, but it's well controlled. Okay, thank you. So those are the parameters that can actually suggest, yes?
Can we also talk about the cigarettes?
Yeah, cigarette can be a risk factor. Yes, that can actually consistent because she is actually having history of smoking, so it can actually increase the risk of having DM. Then,
Sir,
yes,
just a clarification. About the history, we are like talking about even we include the risk factors in that in it.
Yes, because that is also, yes, because that is actually having a history when the patient is actually having most likely to develop type 2 DM. Have you seen even like about the history of like childbirth, which is overweight, macrosomia? So most likely there was something which was not found out, like the patient can have even a gestational DM, but it was not detected during like gestation period, despite the macrosomia. But that is an indicator the patient can have gestational DM, but progress to type 2 DM later after delivery. So that is also like one possible history that can actually increase the possible risk of type 2 DM. So we're supposed to include that one.
Okay.
Okay, fine. So those are the most important pointers. I think Anita has highlighted everything. So the glycated hemoglobin, the fasting blood sugar level, and even age. Have you seen normally her age? It is above 40. So how old is she? 45. Huh? So even her age is actually consistent, huh? Which is consistent for her diagnosis. Yes. Then we have mentioned about delivery of large babies. That is also very important. Family history of DM has already said that. And even central obesity that can cause insulin resistance. So those are the possible physical examination and history that are consistent with the diagnosis of type 2 DM. Then, what should be the goal of therapy for this patient? What would be the goal of therapy? I don't think so. There is a need to give time to think about it. So what will be the goals of therapy for this case? The goals of therapy is, they're still the same.
So can I try?
Yes, please.
You should encourage her to be physically active.
Yes.
Attaining normal blood glucose levels, to achieve a healthy body weight. She should avoid tobacco smoking.
Yes.
And yeah, that's it.
Okay, yes. Then apart from that, have you seen from the history she was taking constantly about a glass of, okay, orange juice, okay, soda, regular soda. Okay, the juice might not be a problem, but the soda is actually having a lot of sugar. So those are not recommended. So generally, the goals of therapy for this condition is eliminating the symptoms of hyperglycemia. That is very important. Avoiding hypoglycemia and reducing cardiovascular complication, or generally preventing or progression of any macro and microvascular complications of DM. By the way, the macrovascular complications are the one we're saying about the possibility of stroke, the coronary artery disease. Yes, yeah, those are the macrovascular complications. The micro ones are the retinopathy, then diabetic nephropathy, and also the peripheral neuropathy. Those are the microvascular complications because they're actually affecting the small blood vessels. Okay, then what kind of biochemical index are we supposed to monitor? So we're just actually looking the fasting and the postprandial sugar level, the glycated hemoglobin, and the fasting triglyceride levels, as well as the LDL cholesterol and HDL cholesterol are the one. Those are the biochemical indexes we're supposed to monitor. Okay, so this one is straightforward. Then how should LH be managed initially? What are the possible treatment modalities like in the managing this condition? Fez Okelo?
Pharmacological management. She's encouraged to do exercise, to eat healthy food.
Yes.
She must be physically active.
Okay, fine. Lifestyle modification. Yes. Is she eligible to initiate pharmacological therapy? Okay, maybe other person, I think his connection is not good, like from my observation. Any other person who can try? Geoffrey? Let me give a chance for others. Geoffrey? And we are checking whether they are available or not. Geoffrey?
Yes, sir.
Okay, you are available or you wake up, huh?
So can I pass the question as I
want
think
to
about
pass.
it?
You just try. Is she eligible to initiate pharmacological therapy? I will not allow you to pass, please. You just try. Is she eligible? And why? Okay. Any other person?
Can I try?
So can we...
Yes, Tiffany. Okay, try.
Okay, so we normally base management on the glycated hemoglobin percentage, and hers was 8.2%, which makes her eligible for dual therapy with metformin and another hypoglycemic agent.
Yes, yeah, there is a possibility of dual therapy. But when do we consider like lifestyle modification, like in diabetic patients? When do we consider lifestyle modification alone?
When they're pre-diabetic.
Yes, when they're only pre-diabetes, yes. Yeah, when the sugar level is between 100 to 125, that is when you are going to increase to do lifestyle modification alone. But otherwise, if a patient is actually diabetic, like above or equal 126 fasting sugar level, now this is when we are supposed to actually initiate lifestyle modification along with pharmacological treatment modalities. Okay, then. So why metformin is the first line drug, Tiffany? Why you choose metformin?
Well, for this patient specifically, metformin is good for achieving glycemic control, as well as reducing her obesity, because we saw the high triglyceride levels that she presented with. So in general, when you combine the glycemic control, that would prevent long-term complications and reducing her triglyceride levels, so preventing her from getting cardiovascular disease, metformin is the best drug to go with.
Yes, yeah. According to even the AD recommendation, according to the various studies, so for any type of type 2 DM patient, unless there is no contraindication, metformin is the front line in the management. Then in case, if the metformin is actually not tolerated, maybe we can use any other monotherapy from oral hypoglycemic agent. Then apart from that, when the glycated hemoglobin is actually very, very high, like maybe that is when we are going to initiate insulin therapy most of the time. So like from the practice, most of the clinician will not go to insulin therapy, but mostly like they usually give combination therapy first before they initiate metformin. Sorry, before they initiate insulin. Okay, fine. I think you have already said lifestyle modifications are very, very important, and specifically this patient is actually having most likely type 2 DM due to insulin resistance because she is actually overweight. Then she's supposed to like moderate her lifestyle modification. That is very, very important. The low fat and low cholesterol diet is very important, and regular exercise and smoking cessation is very important because I think her lifestyle is just like sedentary lifestyle when you look at from the history. Then that is very, very important. Then remember, metformin will be the best, as I said before. LH should take metformin 500 grams twice daily with food. But when you look at her glycemic control, it is a bit higher and she's actually eligible even to take dual therapy. But when the glycated hemoglobin is actually not very, very high, sometimes even lifestyle modification with metformin can work. But according to ADA guideline, and the glycated hemoglobin is actually after 7.6 to like 9, usually dual therapy is usually recommended. So sometimes there is a difference in like in the practice. Some people they just actually recommend when the glycated hemoglobin is not very high, they just initiate lifestyle modification along with metformin. Then after that, they actually titrate and look at the response from the patient. But the general recommendation, according to ADA, is dual pharmacological therapy will be the best treatment modality. Now, the patient has already started metformin. Now, the next question is, LH is started on metformin 500 BD with food. So why metformin is usually recommended to take along with food? Why metformin is recommended to take along with food?
Because of the GI effects.
Yeah, because of the GI adverse effect, like the bloating, the diarrhea, and anorexia is actually very notorious if metformin is actually given on an empty stomach. So most of the time, you have to give proper instruction. Metformin should be taken with food, and you have to start with like slow. Initial is usually like a slow dose, like smaller dose is usually initiated because of the GI side effect. Then, and most of the side effect of the GI side effect of metformin usually subsides like 2 weeks after treatment. Now, she's actually on metformin with food and instructed to increase her doses to 500 milligram every morning and to take to increase her doses to 500 milligram every morning and 1000 milligram every evening after 1 week. Okay, then 3 days after starting metformin, now she actually gave a call to the clinic complaining nausea and diarrhea. She admitted to taking her doses on an empty stomach. So how should LH symptom be addressed? So how do you address this condition? Are we going to take antiemetic medication? Or what special actual instruction can we give? Or how do we resolve this condition? Angela. Angela, can you try? Can you try?
Can you say, first of all, we should advise the patient to, like you said, to take the drugs when with food instead of an empty stomach, so that she can be able to reduce the GI effects. And then also maybe because now her dose was increased to 1000 milligrams every evening instead of 500 milligrams every morning and every evening, maybe we can lower those so that we can see if the symptoms will decrease, because maybe they are very pronounced because of the high dosage in the evening.
Yes, exactly. Thank you so much, Angela. So what you can do when you encounter like a lot of complaints, GI complaints is due to metformin, what you can do is look at how much dose the patient is actually taking. So by looking, then you have to actually request whether the patient is actually taking along with food or not. Like this patient normally admits she took her medicine on an empty stomach. That was the problem, and that was why this problem happened most of the time. So we have to give clear instruction to actually take the medicine along with food. That is good. Then apart from that, if the patient is actually taking higher dose, maybe we can divide. You know, metformin can be given up to even 3 times per day. So you can actually even divide the doses like 3 times, or maybe large dose of metformin can be taken when the patient is actually taking heavy meal. So like when the patient is actually taking heavy meal, maybe in the afternoon or maybe in the evening hours, that is the time she's supposed to take in order to minimize those adverse effects. So remember, GI disturbance such as diarrhea, bloating, anorexia, abdominal discomfort, nausea, and metallic taste. Even metallic taste often dissipate with time and can be minimized by initiating metformin in a single 500 or 850 milligram dose at breakfast or with the patient's largest meal of the day. So remember, for metformin to be tolerated, you have to initiate with a small dose first. Then after that, when the GI effect is actually, when the patient is tolerating the GI effect, that's when they are going to increase the dose. That is general recommendation. So consistent taking of metformin with food significantly minimizes the GI side effect, and the dose shall be increased slowly, like 500 milligrams per day every 2 weeks. That is the recommendation until the appropriate clinical effect is achieved. So until the maximum dose, we have to actually titrate every 2 weeks because the side effects usually disappear with continuous use of metformin. That is the general recommendation. So also, we can actually even reduce the dose, but it should be dependent on the glycemic control. But usually, slow dose is usually recommended until the patient can tolerate. But of course, we can also divide the doses. We can actually even divide the doses. So we can give 2 to 3 times daily dose can also be recommended. So those are the strategies like to reduce the ADRs or GI side effects due to metformin. Then the next question is, how should metformin therapy be monitored? So how do we monitor the metformin therapy for this patient? So what are the strategies to monitor? Or indirectly, what monitoring parameter are we supposed to monitor when a patient is on metformin therapy? Kangai? Kangai, are you available or?
Pardon?
So what is your opinion? What monitoring parameter are we supposed to consider when a patient is on metformin therapy?
I'm not sure, sir.
Even a single, even like a single word about, you remember metformin is like the commonest drug from anti-diabetic medication. You are supposed to know what like all available evidence about metformin.
Yeah. So that topic, I'll require time with it.
Okay, fine. Then
I have that time.
Okay, no problem. Then Kate. Kate, what is your opinion?
I would say since metformin does not cause increase in weight, we can measure the triglyceride levels to see if maybe it's working or not, or the fact that it causes GI disturbances. We can keep on checking if the patient was getting those GI disturbances.
Okay, good. Yeah, we have to look at the GIT aspects because metformin can actually even cause GI side effects, especially during the initiation of treatment and the patient is initiating the therapy. Okay, good. Any other conditions? Oliver?
Yes, sir.
So,
can we say we can measure the plasma levels of vitamin? I don't know if it's possible, vitamin B12, because metformin normally interferes with the absorption of vitamin B12.
Yes, especially if the patient is actually on chronic use. By the way, if a patient is taking metformin for 4 years, it can actually even causes deficiency of vitamin B12, like by 19%. So when a patient has been taking metformin, they are supposed to check the possibility of like our serum level of vitamin B12. It is possible to measure. Okay, good. Any other condition? Any other condition? Thank you, Oliver. Then any other person? Are those the only parameter we are going to look at? We can actually, of course, look at the glycated hemoglobin and also the sugar level.
So can you talk about the kidney function test?
Yes,
Like
kidney function
kidney
test.
monitoring.
What is the essence of kidney function test? You have to tell us the importance of kidney function test when the patient is on metformin therapy.
Can we say because of its capacity to cause lactic acidosis, it is important to check kidney function tests, as well as the fact that you could get toxic levels because metformin is cleared via the kidney?
Yes. Okay. What we fear with metformin toxicity is not about the risk of hypoglycemia, especially in kidney patients. What we fear is about the if the kidney function is declining, the probability of occurrence of lactic acidosis is actually very high because metformin promotes anaerobic metabolism and it actually generates lactic acidosis. Remember, we have discussed about pyruvate 2. Pyruvate normally, like, and after glucose undergo glycolysis, it produces pyruvate. Then pyruvate by pyruvate dehydrogenase enzyme, it can be converted to acetyl-CoA. So acetyl-CoA is the precursor for the Krebs cycle, so that it can actually generate more ATP. However, when the patient is taking metformin, like this pyruvate can be like the enzyme can be inhibited by metformin. Now pyruvate can undergo anaerobic metabolism to generate lactic acid. So there is high risk of lactic acidosis. So because of that reason, we have to monitor the renal function. Is very, very important. As I mentioned before, when the GFR is less than 30 ml per minute, metformin is absolutely contraindicated, even renal patient. But remember, absolutely contraindicated to manage the sugar level. Remember, like insulin is the best treatment modalities or the preferred treatment modalities to manage sugar level when a patient is having kidney problem. Because the other, despite some of them are actually safe, like most of the guidelines recommend insulin will be the preferred in kidney problem patients, but we are supposed to adjust the dose. Okay, fine. So let us see together. The sugar level is very important and kidney function test is very important. The CBC is just to see whether the patient developed like megaloblastic anemia as a result of B12 deficiency. So how do you know, by the way, how do you know whether the patient is having a megaloblastic anemia using the CBC result? How do you know whether the patient is having megaloblastic anemia due to folic acid deficiency or vitamin B12 deficiency based on the CBC result? Any trial?
Can we say the increased size of red blood cells?
Yes, the increased size, but how do we know whether the size of RBCs is actually larger or smaller?
Microscopic examination.
Microscopic examination can also be done, but okay, yes, but there is some simple parameter Microscopy can, I agree, by the way, because most of the time when you look at the normal, when you look at as a result of BTL deficiency, like the size of the RBC becomes bigger. But there is another parameter we are going to look at without even looking or without having the microscopy result.
Checking the hemoglobin levels.
What will be the hemoglobin level?
It's going to be, I think, greater than 13, not sure.
No, why? How does the hemoglobin level?
Oh, less than. No, it's going to be less than.
But will it tell us, okay, when it is less than, it will tell us the patient is having anemia. Will it tell us like the anemia is due to vitamin B12 deficiency or folic acid deficiency? It will tell us the patient is having anemia, but it does not tell us whether the patient is, does it tell us the patient is having anemia due to deficiency of vitamin B12?
I'm not sure, but using MCV, mean corpuscle volume.
Yes, MCV. Yeah, MCV is actually the one that will tell us whether the patient is actually having microcytic anemia in case of iron deficiency or macrocytic in case. So MCV is usually above 100 when a patient is vitamin B12 deficiency. So most of the clinicians, they just actually refer the MCV value so that it is usually above 100 and it indicates there is macrocytis or the size of RBCs are actually becoming very big, but very few in number. Because they are very big and few in number, the hemoglobin level is actually usually very low. Okay, so MCV is the one which we normally do. Of course, we're supposed to do even liver function test. Remember, metformin can also be metabolized by the liver. So there is a possibility to monitor. Then apart from that, we need to also check the possibility of lactic acidosis, despite it is very rare. So what are the major warning signs of lactic acidosis? Shortness of breath, weakness, and malaise. So those are the symptoms of the possibility of having lactic acidosis as a result of metformin therapy. So those are the parameters we need to consider. So are we together? Huh? I'm assuming normally you are learning something like every slide. So are we together?
Yes.
Okay, good. Now, let me give you like few minutes, like 3 minutes to take, like to go through this case study. Then I will get back to you after 3 minutes.
So CA is a 23-year-old woman and has a history of type 2 diabetes and mild renal dysfunction. So from the renal function test, you can see the parameters there. Her son, when she experienced lethargy and was sleepy, so he assumed she was having a low sugar reaction. The blood glucose when the paramedics arrived was 46 milligrams per DL, and she was able to be aroused, and she drank 4 ounces of orange juice. So her blood glucose level raised to 80 milligrams per DL. So she was given another 4 ounces of juice, of orange juice. CA's diabetes has been well controlled by the sulfonylurea, the glyburide 10 mg thrice, and metformin 50 mg thrice. For the past 3 days, she has been eating less and been vomiting and has a flu. So I'd say she was experiencing side effects of the sulfonylurea, and yeah, I think that's what I'd say.
Okay, fine. So the most likely cause for her condition is sulfonylureas, yes? Okay, good. So were there any predisposing factor for this condition? So what are the most likely causes of hypoglycemia? Of course, hypoglycemia episode is very likely with metformin. So the hypoglycemic episode is most likely because of glyburide, which is sulfonylureas. Okay, good. So were there any predisposing factor for the patient to have this episode? Have you seen any predisposing factor from the patient?
She's an elderly woman.
Yes,
and
age.
She has impairment, and she's on high doses of the drug.
Okay, yes.
And she has decreased carbohydrate intake, so that causes disappetite and vomiting.
Yes, exactly, yes. So those are the predisposing factor. So like, remember, even in the face of decreased carbohydrate intake, like reduced appetite and vomiting, she continue to take her usual dose of glyburide. So this ultimately even actually predispose the patient to have what? To have hypoglycemia, because she was not taking very well because of appetite and vomiting, but this one increases the risk. Also, even stress can actually even increase the risk of hypoglycemia. Despite stress increase the sugar level, still because of the reduced intake of food, it can actually predispose the patient to have this condition. Then apart from that, glyburide is actually having a longer duration of action. So it can cause hypoglycemia for several hours. Because of long-term effects, it can actually even causes or predispose the patient to have the symptoms of hypoglycemia. Okay, then. So this one, maybe let us see together. BR is a 60-year-old man with cirrhosis of the liver. He was having cirrhosis of the liver. He's found to have even type 2 DM. Then he has been initiated with glipizide, 10 milligram daily per day is initiated. However, how will BR liver function affect the disposition of glipizide and his response to therapy? This one is about the use of sulfonylureas in cirrhotic patients. As a general recommendation, most of non-insulin anti-diabetic medication should be avoided in a patient with severe liver disease because they are usually metabolized by liver enzyme. So when a patient is having cirrhosis, insulin is often the safest options of anti-diabetic medication. Remember, hepatic metabolism is the primary route of elimination for most of sulfonylureas, including glipizide. So when you give sulfonylureas for this patient, we are expecting exaggerated response because of reduced elimination. So, like the liver function, or like this liver function status of the patient will actually affect the elimination of glycoside from the serum and ultimately increases the risk of hypoglycemia. So generally sulfonylureas are relatively contraindicated for cirrhotic patients, but if they are supposed to be used, most likely the short-acting agents are usually preferred with small initial doses. So it is not an absolute contraindication, it is a relative contraindication that can be used with dose adjustment. So for this patient, most likely we are supposed to give like a dose of 2.5 milligram per day for this cirrhotic patient. But at the general rule, insulin therapy will be the safest option when a patient is having liver problem. So this is all what I have for today. If you are having any question, you are welcome.